In Section 4, we will continue our examination by looking in detail at how CCGs and foundation trusts are governed. Clinical Commissioning Groups, or CCGs, are membership organisations made up of local general practices. Each of the practices locally has a representative on the CCG's Council of Members, and it is the Council of Members who elect which GPs will represent them on their governing body. Legally, the Council of Members delegates power to the governing body to lead the organisation and take it forward on their behalf. The number of GPs on a CCG governing body can vary between 2 and up to 10. They work part-time and get an allowance for the work they do. They might work 1 day a week or 1 day a month for the CCG, as the rest of the time there will be GP partners or salaried GPs working in local practices. The other groups represented on the governing body are the executives, the accountable officer, who is in effect the chief executive of the CCG, and the chief finance officer. There are also at least 2 lay representatives who will have responsibility, respectively, for patient and public involvement, and also for governance, to ensure decisions are made properly. There are other governing body members in addition to these, namely a secondary care clinician working in a hospital or mental health trust, but not in the same health economy, so there is no conflict of interest. Also, there will be a nurse. This change came about when the Health and Social Care Bill was paused while it was going through Parliament, as it was felt that a secondary care perspective was needed to help GPs make better decisions about which services should be commissioned. So the accountable officer and chief finance officer, together with lay representatives, the secondary care clinician and nurse, and the local GPs drawn from the local area, form the governing body. There will also be subcommittees, in particular, most likely, a clinical executive, where a wider range of health professionals are likely to be represented. They make recommendations to the governing body about new and changing services, such as mental health, planned care, urgent care, or long-term conditions. The CCGs are appraised by NHS England annually through a form of 360-degree survey to ensure they are fulfilling their statutory obligations. Local organisations such as the Council, which might co-commission with the CCG, local providers, Healthwatch and so on, will be asked for their views about whether the CCG is working effectively. Now let's look at how foundation trusts are governed. This is a concept which was developed by the Labour government, supported by the coalition government, and continued by the Conservative government. It was seen originally as a reward for providing high-quality patient care and managing the organisation's finances well. Hospitals, mental health trusts, community services trusts, and ambulance trusts are all allowed to apply to become foundation trusts. In order to become a foundation trust, you have to prove that you have an integrated business plan that sets out a clear direction for the next 5 years. They must also demonstrate that they are well governed and understand the economic and quality issues. They must have an effective board, and they must recruit members. Foundation trusts are also membership organisations, but in a different way to clinical commissioning groups. They are legally defined as public benefit organisations, which are given autonomy over their own decisions, but are accountable for those decisions to their local patients and public. The major difference is that if they make a financial surplus, they are allowed to keep it, and also they can borrow money on the external market. They must encourage the local public, patients and their staff to in effect join their club. It doesn't cost anything to become a member. Once you join, you will be sent information about events, about the services provided, and how the organisation works. But you're entitled to seek nomination and to be elected onto the Council of Governors. 50% plus one of the governors must be members of the public, and others can be staff. There are also appointed governors from the local health economy. Usually these include representatives of local CCGs, local councils, universities and medical schools. The Council of Governors oversees the work of the whole organisation, in particular the work of the board. The chair of the board will also be the chair of the council. The governors are authorised to appoint both the chair and the non-executives on the board. In turn, it is the responsibility of the chair and the non-executive directors to appoint the executive directors onto the board and hold them to account. Non-executive directors are normally people from various professions, often finance or law, who are appointed on a part-time basis. Their job is to appoint the executives, who are usually full-time salaried employees, and to hold them to account. The role of non-executive director is often described as that of a critical friend. They have to maintain a healthy balance of support and constructive challenge. Their job is to ensure that decisions made are effective and properly implemented. The executives on the board of a foundation trust will include the chief executive, who is responsible for the overall running of the organisation, the finance director, medical director and nursing director, and often there will be directors of HR, corporate affairs and sometimes estates. As foundation trusts have greater independence and are stand-alone organisations, they have to have legal contracts in place with their CCGs rather than service-level agreements. Therefore, it can be important to have a legally qualified trust board secretary. They will often also have commercial or business development directors, who are often clinicians with an MBA or accountancy qualification, people who can straddle the clinical and business world and are responsible for the development and promotion of new and improved services to earn greater levels of income and ensure future cash flows are as secure as they can be. The duties of foundation trusts are largely to ensure that they manage within their means, that they provide a healthy cash flow and that services to patients are of the highest possible quality. The services provided are coded, and it is these codes which are transferred onto invoices which are sent to the CCG or NHS England if they provide specialist services. They can develop partnerships, and some of the larger hospitals have developed alliances with local medical schools, research foundations and charities. There were several changes made as a result of the Health and Social Care Act 2012 which affected foundation trusts. First, they must hold their board meetings in public, just like CCGs. Secondly, they are able to generate up to 49% of their equivalent NHS income privately. Thirdly, in the event that they fail to fulfil their legal responsibilities, they can be liquidated in the same way that a private company can, and their services will be taken over by other organisations. The first two organisations to go through this process of liquidation are the South London Hospitals NHS Foundation Trust and the Mid Staffordshire Hospital NHS Foundation Trust. That ends section 4, which has looked in detail at the governance arrangement for CCGs and foundation trusts.